Next is by Dr. Newet Lumi on Ruthenium 106 episcleral brachytherapy in ocular tumours, experience from a tertiary center.
So very good morning to you all. So I'll be speaking on Ruthenium 106 ocular plaque brachytherapy in ocular tumors from an experience from a tertiary center. So I have no financial interest to disclose. So we all know that for the past 2 decades in our country also, the brachytherapy has been widely accepted treatment modalities for most of the ocular tumors. And the advantage is that the treatment is targeted to the tumor and the radiation exposure to the surrounding structure is minimal with minimal side effect. And the radioisotope commonly used in our country is iodine-125 and ruthenium-106. So the aim and objective of this study is to report our experience on episcleral ruthenium-106 plaque brachytherapy for different ocular tumors with regard to globe salvage, tumor control, visual outcome, and complications. So it is a retrospective intervention case series conducted at Dr. R.P. Center, AIMS, New Delhi. Study was taken from April 2017 to June 2020, and an appropriate institutional clearance and consent were taken. We used the ruthenium-106 baby plaque in all our cases. So coming to the inclusion criteria, we include the tumors of apical thickness less than 6 mm and a larger basal diameter of 15 mm. And for regarding retinoblastoma, we have done the secondary brachytherapy on patients which are refractory to this systemic chemotherapy after 6 cycles or with or without any focal therapy. And for the ocular surface tumor with margin positive on histopathology and with the scleral invasion was seen on intersectional OCT and UBM. On exclusion criteria were those active vitreous or subretinoblastoma seeds, painful blind eye, orbital involvement, pre-treatment systemic metastasis, and previous radiotherapy. So the dosimetry calculation was done using an Excel sheet manual calculation by a medical physicist. So what are the parameters which they require, like the tumor dimensions, the location of tumors, the measurement of tumor distance from optic nerve and the fovea, and based on it they calculate the duration of the plaque in situ, and then the shape and size of the plaque is decided. The standard procedure was carried out in all the cases under the supervision of the radiation safety officer. And in follow-up, the best corrected visual acuity were assessed, the detailed ocular examinations and the radiation-related complications were observed. Ultrasound was done for the local tumor measurements, and the yearly PET-CT scan was done on the whole body to rule out any systemic metastasis. So this is the result of our case series. Retinoblastoma, we have 18 eyes, choroidal melanoma 13 eyes, choroidal hemangioma 15 eyes, and ovocystin 8 eyes, and an average follow-up of around 25 months for retinoblastoma, choroidal melanoma around 20.69, and choroidal hemangioma around 30 months, and then ovocystin around 13 months. So the mean dose of radiation dose at apex for retinoblastoma is around 40 gray, and then for choroidal melanoma is around 80 gray, and hemangioma is around 40 gray, and ovocystin is around 60 gray. So the tumor apical thickness is around 3.6 millimeter for retinoblastoma. For melanoma is around 5.4 millimeter, and choroidal hemangioma is around 4.4 millimeter, and ovocystin around 0.6 millimeter depth of scleral involvement. So coming to these outcomes of retinoblastoma, we found that the visual acuity and IOP, there was no clinically significant difference in baseline and 12 months follow-up. Similarly, in choroidal melanoma too. However, in case of this tumor dimension, in case of basal diameter and also apical thickness, we do see the change in decrease in the tumor dimension. And also, when we see in case of choroidal hemangioma and ovocystin also, here also we do found no clinically significant difference in baseline and 12 months in terms of visual acuity and intraocular pressures. However, the basal dimension and then apical thickness was clinically significant was seen in baseline and 12 months follow-up. The average globe salvage rate in retinoblastoma is around 77%, choroidal melanoma around 76.9, OSSN is around 62, and hemangioma is around 100%. The average local tumor control rate at 12 months is around 75% in retinoblastoma cases, and choroidal melanoma is around 66.6%, and OSSN around 62.5, and then hemangioma is 100%. Coming to complication, we found 4 cases of proliferative retinopathy, which was subsequently subject to enucleation in case of retinoblastoma. For melanoma, one case has distant metastasis, and which was subsequently he got expired. That there were 3 radiation retinopathy. In OSSN, there were 2 recurrences, local recurrences, and 1 orbital invasions. And in choroidal hemangioma, there's 2 radiation retinopathy. So we reviewed literature. We found that in one study by Squirrel et al. In 2006, where they had done plaque brachytherapy using Ruthenium 106 in 134 patients with a mean tumor thickness of 3.7 millimeter. Here, the 5 years tumor control rate is 94.4%, and preservation rate, globe preservation rate is 86.5%. Another study by Masood et al. On 21 eyes of circumcised choroidal hemangioma with tumor thickness of 3.7 millimeters. So after 1 year, they have shown a good response in this case also. Another study by Lomat et al. In 2000, where they have done 141 eyes on posterior uveal melanoma with a mean tumor thickness of 2.7 millimeter. We have shown a local tumor control rate of 63.2% and eye salvage rate of 65.6%. So here's a study, here's a picture, clinical picture of our case where a plaque brachytherapy was done, and this is the 16-month post brachytherapy, showing a good regress response. Another case of choroidal melanoma, after 13 months follow-up, patient is the tumor response is quite good in this case also. In case of diffuse choroidal hemangioma with serious detachment, we found a good response here again in this case, and 18 months post brachytherapy. Another case of OSSN post surgical excision followed by the brachytherapy. 11 months follow-up, the patient is doing well now. So in conclusion, with proper care selection and experience, Ruthenium 106 plaque brachytherapy is a promotion modality for an effective eye and vision sparing alternative to enucleation for patients of intraocular tumors with a good overall tumor control and globe salvage rate. So the limitation of our study is it's a retrospective study design, a small sample size, and a short duration of follow-up. So these are our references, and I thanks our this brachytherapy team under the guidance of Professor Bhavna Chawla, and also acknowledge our radiation oncologist Dr. Susmita Petty and Dr. Subramani, our RSO. Thank you.
Thank you. That was a nice presentation. Just one question. I noticed you had a couple of patients of radiation retinopathy in the choroidal hemangioma group, and your mean radiation dose provided was around 40 gray.
Yeah.
So, would you comment upon if, because for being a benign tumor and the aim of treatment being stabilizing the tumor dimension and reducing and basically stabilizing visual acuity, would you like to reduce the dose provided for choroidal hemangiomas, considering radiation retinopathy post would need further treatment?
Yes, basically we have seen one case in, I think I remember one case only in case of choroidal hemangioma where there's radiation retinopathy was there. So in that patient, we have done standard dose of 40 gray was given in the apical the dose, and I don't know how their tumor response differently with the different patient might be, but we do see this case, particular case, maybe that patient was associated with hypertension and diabetic also. Maybe that had increased the chances of getting radiation retinopathy.
Possible, yeah. Great.